Okay, so today we're going to be going over cardiomyopathy. So it's going to be dilated, restrictive, and hypertrophic cardiomyopathy. This is from the cardiology section for the PANCE, which is about 13%. So it's a pretty big chunk of the PANCE. You definitely need to know these things. And I just wanted to thank everybody for the comments, the likes, and if you don't mind subscribing, I'm going to be coming out with new content pretty much every week. And thank you so much again for the likes and the comments. I really do appreciate it. So really quickly, before we get into the cardiomyopathies, I just wanted to refresh everybody. On heart failure. I'm sure you're all probably pretty familiar with this, but really quickly, let's just go over just in case you've forgotten some of the things. So you have systolic and diastolic heart failure. So systolic is going to be when the ventricles are going to be thin, weakened, they're going to be stretched out, and they're going to be overly compliant, which means that they're going to not pump very well. They're not strong. They're just kind of baggy and hanging around. The muscle is not very strong, so you're going to have a decreased ejection fraction. So the blood that's pumped out of the heart in each beat is going to be decreased, sometimes dramatically decreased. So you're not getting enough blood out to the body. It's all backing up in these ventricles. And then what you hear on auscultation, typically with systolic heart failure, is something known as an S3 or an S3 gallop. And you hear this noise because the atrium is splashing the blood down against these baggy, thinned out ventricles. And when the blood hits these baggy ventricles, you hear something known as an S3 gallop. Now, diastolic is kind of going to be the opposite. So the ventricles are okay, the muscles work okay, they pump fine, but they're going to become stiffened or thick, and they're not going to relax the way they should. And if the ventricles aren't relaxing, blood can't fill the ventricles. So it's all going to back up into the atrium the same way because they can't get into the ventricles. The ventricles won't open. They're stiff. They're non-compliant. So as far as pumping, the ejection fraction is normal. The heart is actually pumping okay, so ejection fraction will normally be normal in diastolic heart failure. But again, they're not opening the way they should. Not enough blood is getting into the ventricles. And then on diastolic heart failure, you'll hear an S4. So the way that I remember that you're going to hear an S3 on systolic heart failure is, actually I'll go over that in one sec. So let me just a really quick picture. So systolic and diastolic heart failure, this is just a quick diagram. So you can see systolic is going to have these thin stretched out chambers, and then diastolic you're going to have these thickened and sometimes stiffened ventricles. So they don't open, you can't get as much blood into the ventricle. So these are the kind of like the polar opposites of each other. And that's what it looks like on a diagram. So again, what I was saying before, so S3, the way I remember S3 is going to be with systolic heart failure. Again, remember like I just went over, systolic heart failure is these thin, wide open, baggy ventricles, and you hear an S3 on a systolic heart failure. So the way to remember that, if you take a look at a 3 and you rest it on its back, what does that look like? It looks like the bottom of a heart, and it looks like these wide open, baggy ventricles. So that's how I remember you hear S3 on systolic heart failure. And then if you remember here S3, you know, what's the only other one? That would be S4, so that's diastolic. So S3, big, wide open, baggy ventricles heard on systolic heart failure. And then you take a look at a 3 on its side, and that's kind of looks like those baggy ventricles to me. So now one other thing I wanted to go over really quick is the difference between left and right-sided heart failure. So left-sided and right-sided heart failure, all you have to think about is where's the blood coming from, and wherever it's coming from because of the heart failure, it's going to be backing up into that area, and you'll have symptoms related to that area. So left-sided, where's the blood coming from? Where's the blood coming from the left side of the heart? It's coming from the lungs via the pulmonary vein. So if the blood's not pumping out or it can't get into the ventricles, it's going to back up and it's going to go back into the lungs. So you're going to have dyspnea, pulmonary edema, congestion. And then how do you remember that left-sided heart failure is going to back to the lungs? You're going to have lung symptoms or pulmonary symptoms. Remember, left-sided, left, L stands for lungs. So right-sided, flu is going to back up where it came from. Where is that? That's the IVC and the SVC. So you're going to have pretty much the rest of the body. You're going to have symptoms in peripheral edema in the legs. You're going to have jugular venous distension. You're going to have hepatic congestion. It's all going to back up into the GI system. So R, the way I remembered it, is R stands for rest of the body because it's everywhere else. Everything coming from the IVC and the SVC, which is pretty much everything except for you know, so you'll just see the lungs on the left side, but the rest of the body is going to be right-sided heart failure. So that's why I remember those two and the symptoms you'll have. And then just a really quick diagram to kind of just reinforce what I just said. So right-sided, this is a really simplified. Obviously, you'll have an SVC and an SVC separately. But right-sided, if it's backing up here from the ventricle into the atrium, it's going to go back to the rest of the body. Left-sided, if it's backing up at the ventricle into the atrium, it's going to go back to the lungs via the pulmonary vein. So really quick review of heart failure. So let's move into dilated cardiomyopathy and go over that. So dilated cardiomyopathy is going to be when you have these dilated, baggy ventricles, which is going to lead to impaired contraction. So your systolic function is going to suffer. These ventricles are dilated, exactly like it says. They're stretched out. If you think of like a piece of gum, when you stretch it out, it gets really thin, or Play-Doh. It's the same thing that's happening to these ventricles. And because of that, they become really weakened, and you're going to have impaired contraction. Now, it's the most common type of cardiomyopathy. 90, sometimes as high as 95% of all cases of cardiomyopathy are dilated. So this is the one that's really important because it's the most common, the one that you'll most commonly see in real life. Ventricles, again, like I said, are baggy, stretched out, and weak. And that's what this looks like. So a normal heart here, you can see the normal diameter of the ventricles. In dilated cardiomyopathy, it's stretched out, it's wide open, and you can see the ventricles are very thin. So the muscle is going to be weak. That blood's not going to pump out the way it should. It's going to get backed up here, and then of course back up into the rest of the body, depending on the side that's most prevalent. Sometimes both sides. Now, as far as etiologies, your most common etiology is going to be idiopathic. So it's about 50% of the cases, most common cause. And then there's a few other ones you need to know as well. And these are pretty important because I do remember these coming up pretty frequently. So alcohol and cocaine use, so substance abuse, can cause dilated cardiomyopathy. Doxorubicin, which is a chemotherapy agent, is another important one. And it's funny because it really causes very few cases of dilated cardiomyopathy, probably like less than 1%. But it comes up very often on your exams. So just know that one. It's one of the ones you probably won't see in real life, but you'll definitely see on your exams. Infections, specifically viral, like Coxsackie virus, is another common cause of dilated cardiomyopathy. And then finally, vitamin B1 deficiency can also cause dilated cardiomyopathy. So there's a lot to know, but I really think you should know them. And the way that I came up with this is, I'm actually pretty proud of this mnemonic. But so dilated cardiomyopathy is the only cardiomyopathy that starts with a D. So if you think of dilated cardiomyopathy, think of a D, and think of your 6 Ds of dilated cardiomyopathy as far as your causes. So the first one, drinking alcohol. Second one, don't know, which is going to be your idiopathic. Your third one, deficiency, as in vitamin B1 deficiency. Your fourth, doxorubicin, your chemotherapy agent. Your fifth, drugs, as in cocaine. And then finally, disease, specifically viral disease. So those are your 6 Ds of dilated cardiomyopathy, and that'll help you remember the etiologies. Remember, idiopathic or DNO is going to be your most common cause. Now, moving on to the manifestations, these patients are going to be in systolic heart failure. So you're going to have symptoms of heart failure, and both left and right-sided heart failure. So just like we went over before, if it's left-sided, they're going to have pulmonary symptoms, so dyspnea, cough, wheezing. If it's right-sided, hepatomegaly, jugular venous distension, peripheral edema, all of the symptoms on the right side. So the legs may have all that edema, the pitting edema. They may have the jugular venous distension, which you'll see in the neck. You'll certainly be doing that in your OSCEs, JVD, and you'll just see symptoms in the rest of the body. So nothing really specific, just symptoms of heart failure in general, both right and left side. One thing that you will also see on a physical exam, or hear on a physical exam, is going to be your S3 gallop. And that's pretty important for you to know. That's one of the ones that is, when you see an S3, you definitely should be thinking of systolic. And if you see other symptoms alongside it, you should know that's a pretty hallmark finding for dilated cardiomyopathy. So remember S3 gallop as well. Remember, again, that's you're splashing down on this, the blood splashing down on this overly compliant ventricle. So those are going to be your findings on exam. Now, as far as diagnosis, you're going to see in all the cardiomyopathies, we're going to pretty much diagnose the same way. And that's going to be with echocardiogram. Now, echocardiogram is for dilated cardiomyopathy. You're going to see 3 main things here. So first thing, obviously, you're going to see ventricular dilation, as the name states. Second thing that you're going to see is thin, stretched out ventricular walls, so much thinner than they normally should be. And then finally, you're going to have a decreased ejection fraction, because remember, dilated ventricles, stretched out, very weak. They're not pumping out the blood. The muscles are definitely diminished, so you're going to have decreased ejection fraction, less blood coming out than you should, sometimes as low as in the 30%, 40% range. Normal being, of course, 50, 60% ejection fraction. Now, this is what it looks like on an echo. We kind of shaded it here so you get a better idea. Sometimes they're not very easy to read if you're not familiar with them. So this is a normal size of a ventricle here. And then you can see on this side, this is this wide open, big ventricle, thinned out walls, and just really dilated. So that's what it would look like on an echo. Now, you can also do an x-ray. It's not going to be very specific because a lot of things can cause some of the symptoms you'll see, or some of the x-ray findings, but you'll see cardiomegaly, pleural effusion, and then an x-ray here. You can see this huge heart. It's almost taking up the entire chest. and then pleural effusion. So on a chest x-ray, you should see these pointy costophrenic angles. They should come to a nice point here. But on this side, you can see it's blunted. It's tapered off here. That's because this is all fluid filling up here, so it doesn't have that nice tapered off appearance. It's kind of blunted here on that side. So that's the pleural effusion. Then of course this is your cardiomegaly, this enlarged heart, which is quite large on this person. And you can also do an EKG as well. Again, not very specific, but you're going to see arrhythmias, sinus tachycardia, and those are your ways to diagnose. But the main thing you need to know is your echo. And of course, remember what you're going to see on echo, so you'll be able to diagnose it, at least for the exam, and then in real life as well. So treatment, you're going to treat these patients like you would any other patient with systolic heart failure. So how do you treat systolic heart failure? Well, there's 4 main classes or medications that you need to know that reduce mortality in heart failure. So what are those? ACE inhibitors is going to be your #1 medication class for heart failure. So that's going to be your prils, your lisinopril, catepril, etc. Second line really is going to be your beta blockers. Hydralazine plus nitrates, specifically isosorbide dinitrate is normally the one used with hydralazine, and then spironolactone. Now I put a little asterisk here because you need to know all 4 of these classes or these medications are proven to decrease mortality in patients with heart failure, because there's a lot of meds you can use for heart failure, but not all of them decrease mortality. But these are the 4 that you need to know. Now there are some newer classes of meds. I'm not going to go over them now because I don't think it's going to be on your boards. They are fairly new, but there's one called Entresto, which is similar to ACE inhibitors. It's a neprilysin inhibitor, and it works really well. It can actually reverse some of the causes of heart failure, but it's pretty new. I don't think it's going to be on there. And then also SGLT2 inhibitors. If you remember from diabetes, those are some of the diabetic medications that flush the sugar out through the kidneys. These also work for heart failure, and they work really well. But again, these are newer classes. They're probably not going to be on the boards, but you should know that for real life, because one day you're going to be practicing medicine. So those are something to know as well as a side note. But these are the 4 that you really need to know. And then also go over the ones they use for symptom control. So these do not decrease mortality, but they make your patient feel a lot better. So they are important. So loop diuretics, furosemide, it's going to pull all the fluid off, help these patients feel a little bit better, get the swelling off their legs. And then digoxin increases the contractility of the heart, so it helps it beat better. And that's important because remember, you have this weakened heart muscle, these weakened ventricles. So digoxin helps the contractility of the heart. So these are going to help them feel better, but it won't decrease mortality. So make sure you're able to differentiate the 2. And then finally, in patients with really low ejection fraction, normally 35% or less, history of cardiac arrest, VFib, these patients are going to need an ICD, so implantable cardiac defibrillator. So this is really going to be your last line when these patients are really getting sick, and you need something a little bit more invasive to help them. Now, of all of these, what I think you need to know is those 4 classes, those 4 medications. So how do you remember those? Because those are the ones you really need to know that they're going to ask you. How do you remember that? It's bash the heart to make it beat harder. So just think of your heart's not beating hard, you just kind of like bash it and say, wake up, start beating harder. So BASH stands for beta blockers, ACE inhibitors, spironolactone, and hydralazine, plus your nitrate, of course. So remember that. That's really the ones you need to know for the for real life, really, and for your board. So bash the heart to make it beat harder. Those are the ones with proven mortality benefit in patients with heart failure. Okay, so what do you need to know? I think you need to know that this is a systolic dysfunction that leads to a weakened dilated ventricles. You need to know your 6 Ds, the etiologies that I went over, because those all may come up. You need to know S3 is a hallmark finding on physical exam, and then you need to know your BASH for treatment that we just went over. So those are the things that I really feel like you need to know. If you forget everything else, remember those 4 things. Now moving on to restrictive cardiomyopathy. So this is kind of going to be the opposite. So restrictive cardiomyopathy is caused generally by an infiltrative disease, so whether it's amyloidosis, hemochromatosis, that leads to the stiffening of the ventricle. So the ventricles pump okay, but they're going to become stiff. And when they become stiff, they're not going to relax properly. And if they don't relax and they don't open up on diastole, they're not going to be able to be filled with blood. So you're going to have this diastolic dysfunction. So they're going to beat okay, but they're going to become really stiff. They're not going to open up on diastole, and that means you're not going to get enough blood in. Sometimes it can wind up backing up into the rest of the body. So that's restrictive cardiomyopathy, and this is what it looks like. So here's your normal heart, and then restrictive, you have this thickening, sometimes thickening, not always, more of a stiffening, I'm sorry. So not necessarily thickened, but more of a stiffening of these heart. It can become slightly thickened though, so that is important to know. But it's mostly just a stiffening of these ventricles that allow them to not relax, or so you're going to have problems with your diastole. Now it's rare; it's only about in 1% of the cases of cardiomyopathy compared to dilated, which was about 90 to 95%. So this one's not going to be very common in real life. Certainly doesn't mean you don't need to know it for the boards, but you do need to know that you probably won't see it very often in real life. Now, as far as etiologies, your most common cause is going to be amyloidosis, and then other infiltrative diseases are also really common. So hemochromatosis, sarcoidosis. Now let me explain really quickly why you see these specific etiologies in restrictive cardiomyopathy. So what happens is, for instance, with amyloidosis, if you've gone over this before, you'll remember amyloidosis is abnormal deposits of a protein called amyloids. So they can deposit in the heart, they can deposit in the kidneys, they can deposit in a bunch of organs. But what happens when they deposit in the heart, these amyloid proteins stiffen the ventricles, and it's the same thing in hemochromatosis and sarcoidosis. So sarcoidosis, you're going to have these granuloma deposits that's going to make the heart rock hard. Hemochromatosis, you're going to have these iron deposits. That's also going to make the ventricles really hard. So generally what you need to understand is all of these infiltrated diseases, all these diseases that basically deposit all of these abnormal things in the heart are going to lead to it hardening and getting stiff and not being able to relax. So that's the main idea here. There's some other causes as well, not as common, but radiation, metastatic disease, chemotherapy. And again, because a lot of these, like the radiation and everything, can cause scar tissue and fibrosis in the heart. So a lot of the radiation, chemo, and those types of things. So similar idea, but they're just not as common. Now that's going to be your most common etiologies, amyloidosis, and your infiltrative diseases. The way I remember that is going to be AMY has restrictive cardiomyopathy. So AMY has restrictive cardiomyopathy. What that stands for is AMY stands for amyloidosis. So first three letters in amyloidosis is AMY. So AMY has, and then has stands for hemochromatosis, amyloidosis a second time, and that helps you remember that amyloidosis is your most common cause overall because it comes up twice in this mnemonic. And then finally, the S stands for sarcoidosis. So AMY has restrictive cardiomyopathy, AMY stands for amyloidosis, and then the HAS stands for hemochromatosis, amyloidosis a second time, and then sarcoidosis. So that's going to be the way you remember the etiologies for that. Now moving on to the clinical manifestations. So these patients are going to have heart failure, but it's going to be diastolic heart failure. Now it's going to be more common for them to have right-sided heart failure symptoms. So again, remember what's right-sided. Right-sided, well, left-sided as well, but right-sided you're going to have the hepatomegaly, jugular venous distension, peripheral edema, and then Kussmaul sign also, which we'll go over in a minute, which is pretty important for this. And then left-sided failure, of course, is dyspnea, cough, wheezing. But right-sided is what you're going to see more commonly in restrictive cardiomyopathy. So these are the things you should look for in restrictive cardiomyopathy. And let's go over Kussmaul sign in case you're not familiar with it. So what Kussmaul sign is increased jugular venous pressure with inspiration. Now that's the opposite of what normally happens in the body. So when you take in a deep breath, the lungs expand obviously, and you produce this negative intrathoracic pressure, which decreases the pressure in the chest. And what happens when you decrease that pressure, all of the blood rushes back to the heart, and it fills the right atrium, goes into the right ventricle, and so you're going to have all this filling, and what happens then is the internal jugular vein, which all of that blood was full with, is going to rush back to the heart, and you're going to have this decreased jugular venous pressure. But in a patient with restrictive cardiomyopathy, as the blood is rushing back because of this decreased or this negative intrathoracic pressure, it's rushing back to the heart. But what happens is because the ventricle on the right side is not opening up, it's actually backing up into the right atrium, and then eventually, because all the blood's rushing back there, it's going to back up right back into the internal jugular vein, and you're going to have this increased jugular venous distension. And that's what Kussmaul sign is, and this is what that's actually going to look like. So you're going to have this increased jugular venous pressure with inspiration, which is the opposite of what should be happening in a normal patient. So it's all backing up into the internal jugular vein. So that's what that looks like on a patient, and that's why you measure your JVD on exam for these patients. So that's what you're going to see, and that's a pretty common sign in restrictive cardiomyopathy. So overall, again, remember heart failure symptoms, more common to see right-sided heart failure symptoms. in patients with restrictive cardiomyopathy. Now, diagnosis, you're going to do, again, your echo, just like we did with all of them. And echo is going to show initially probably a normal, maybe slightly thickened ventricles. And then you're also going to have diastolic dysfunction. So you're going to have decreased filling of the ventricles. Your ejection fraction will be normal. As I went over before, it's a little bit misleading because you're still not getting a lot of blood out, but because this is a fraction, it's a percentage of how much is going in and how much is coming out. Less is going into the ventricle. So even though less overall is going out, this is a fraction. So again, what you should know for the exam is going to be typically a normal ejection fraction, but you will have this diastolic dysfunction. And the important thing that you need to know is that you're going to have dilation of the atrium, so atrial dilation. And why does that happen? Well, the atrium is pumping blood into the ventricles, but it's doing so against resistance. These ventricles are not relaxing. So what happens is when they push against resistance, they're eventually going to have this backed up pressure, and they're going to start to dilate. So that's one of the most common things you'll see on an echo of restrictive cardiomyopathy. So these big wide open atrium. So dilation you'll see on echo. Now, the most definitive way to actually diagnose restrictive cardiomyopathy is with an endomyocardial biopsy. So that's actually going in, taking a piece of the heart and doing a biopsy on it. It's not commonly done because it's obviously much more invasive, and you can kind of diagnose from the echo. But if you do it and you do happen to find your most common cause, which is going to be amyloidosis, what you're going to see is this apple green birefringence on staining. It's called Congo red staining. And why do I mention something so ridiculous? Well, it's because it does come up in the exams. I've seen it in questions. So if you ever see a biopsy positive for apple green birefringence, think amyloidosis. And again, amyloidosis isn't just in the heart, so you may see it in the kidneys, other places as well. So remember that you ever see apple green birefringence, you should be thinking amyloidosis. And this is what it actually looks like. So this is just the exam. This is just what it looks like under a microscope, but this is actually the staining with it. It's called Congo red, and you can see this apple green birefringence is what it's called here. So remember that because it definitely may come up. It's one of those weird things that they like to ask. So endomyocardial biopsy is going to be your definitive diagnosis, but generally you're just really going to do an echo. Now, as far as treatment, the main thing that you need to address here is the underlying cause. So is it amyloidosis? Is it hemochromatosis? You're going to do iron chelation. Whatever the cause is, treat the underlying cause, and generally this will improve. You can treat them with diastolic heart failure meds, so beta blockers, calcium channel blockers, furosemide, but really what they're looking for here, the answer is going to be to treat the underlying cause, and then everything else will improve after that. So that's really the main thing you need to know for that. Now, what do you need to know? You need to know this is diastolic dysfunction, so it's a filling defect. These ventricles are hard, they're not opening, they're very stiff, they're non-compliant, and you need to know the most common cause is amyloidosis. Remember, Amy has restrictive cardiomyopathy, and then remember the treatment is generally just to treat the underlying cause. So that's restrictive cardiomyopathy, not a lot to know there. Now let's move into the last one, but I would say probably the most popular of all of these to be asked, and it's hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy is a genetic disorder. It's an autosomal dominant genetic disorder, and you have these mutations in the sarcomere genes. And what the sarcomere genes are responsible for is the contractile portion of the heart. So you have a problem with the contractile portion of the heart, and it's going to lead to this hypertrophy of the left ventricle, and more specifically the septum. And when you have this hypertrophy of the septum, it's going to lead to diastolic dysfunction because you're going to block your outflow to the aorta. And that's what you develop in hypertrophic cardiomyopathy. You have this outflow obstruction. So the septum is going to have this hypertrophy, the left ventricle, and it's going to block the outflow to the aorta. Now, as far as clinical manifestations, there's a wide range. And really quickly, let me just show you what a diagram looks like here. So this is going to be your normal heart. Blood's going to flow from the left ventricle right into the aorta here through the aortic valve. Now, in patients with hypertrophic cardiomyopathy, you have this thickened ventricular septum. The left ventricle is going to thicken as well. So when blood's trying to get out here, because you have this big, puffed out, hypertrophied septum here, it's going to block the outflow. Now, this isn't every patient. Some patients actually don't have an outflow obstruction, and they're asymptomatic. They don't have problems, but it is slightly enlarged here. And then some patients have full-blown hypertrophied septum, and these patients can actually have this can actually cause cardiac failure and death from ventricular fibrillation and things like that, which we'll go over shortly. So that's what that looks like, and that's why you have these symptoms. Now, as far as clinical manifestation, again, like I said, depends on how severe the outflow obstruction is. So there's a wide range. It can be anywhere from asymptomatic to sudden cardiac death. So some patients, again, like maybe asymptomatic. Dyspnea will be your most common symptom just due to the lack of blood flow to the rest of the body. So, hypoxia. Angina is another common one. You're not getting enough blood flow. Fatigue, presyncope or syncope if they're exerting themselves or dehydrated, and then sudden cardiac death is a possibility if they do have exertion, dehydration, which I'll go over the reason for some of those things in a minute. So those are some of the clinical manifestations. Again, wide range of symptoms that you may see. On physical exam, this is really important. I would say probably this is the most important thing that you need to know. So physical exam, you're going to have this harsh systolic murmur that's best heard at the left sternal border. So you really need to know this one. And it's not very specific, just a systolic murmur, harsh systolic murmur. The way you differentiate this from other ones is with some of your tests that you'll do, some of the exam things that you'll do with the patient. So in a normal murmur, most other murmurs, aortic stenosis and some of the other ones, when you have decreased venous return, less blood coming to the heart, normally the murmur is going to decrease because you have less blood going to the heart. You're going to have less blood pumping through this stenotic valve or less regurgitation because there's less blood flow. But in patients with hypertrophic cardiomyopathy, if you have decreased venous return, like when a patient stands and the blood rushes from the heart or a Valsalva maneuver, this is actually going to increase the intensity of the murmur. And the same with the opposite. So if you have increased venous return, so squatting, leg raise, blood rushing back to the heart, blood's coming back into the heart, the murmur is actually going to decrease, which again is the opposite of most other murmurs. And that's how you differentiate this from other ones. So more blood coming to the heart, decreased intensity of the murmur, which is opposite of aortic stenosis and a lot of the other murmurs, and then decreased venous return, less blood coming to the heart, it's actually going to make the murmur worse. And again, the other ones are going to be the opposite, less blood normally coming to the heart, less intensity of the murmur. And so again, this is the opposite of other murmurs. And you're also going to hear S4 and auscultation. So the reason I wanted to go over is because when you have hypertrophic cardiomyopathy, as I showed you before, you have this obstruction. And if you can kind of think of that diagram I had before, let's pull it up here again. So you have the heart here, the normal heart, but this is the one we're looking at, the hypertrophic cardiomyopathy. So you see this obstruction here. Now, if you fill this heart up with blood, what's going to happen here is the blood is going to push this out a little bit, push this out a little bit. And what's going to happen when you fill this with blood and these both push out to the sides? This obstruction is going to decrease. So you have more blood in the heart, the murmur is going to get better. Now you have less blood, their decreased venous return. You're going to have less blood. So this is going to kind of collapse on itself, and this obstruction will get worse. So that's the reason why less blood to the heart is actually going to increase the murmur. You're going to have more obstruction here, and then more blood coming back to the heart, increased venous return. Stretch this out, the obstruction will lessen, and the murmur will actually improve. And that's also the reason why, which I'll go over later, is why patients who become dehydrated or take medications that decreases your venous return or decreases the preload will actually have increase in severity of the symptoms and increase in the obstruction. So again, like I said before, also S4 and auscultation, which is not as important, but you do need to know. You'll have that on a physical exam as well. As far as diagnosis, surprise, surprise, we're going to do an echo. Now your echo in these patients, you're going to have a diagnostic criteria, left ventricular wall of 15 millimeters or more. Or in a patient with history of hypertrophic cardiomyopathy, a family history, you only need to have 13 millimeters of hypertrophy left ventricle or the septum. It's actually the left ventricular wall that you're going to be looking. So either 15 or more in a patient without history, or 13 or more in a patient with family history of hypertrophic cardiomyopathy on echo to diagnose. You can also do an EKG. It's very sensitive. About 90% of patients with hypertrophic cardiomyopathy will have an abnormal EKG, but it's not very specific. So sensitive but not specific. You'll have some repole changes, left axis deviation, and left ventricular hypertrophy. So it's good to do EKG for screening, especially if you're doing like a sports physical on young children who are going to be going out and playing sports for the first time, to screen. But to actually make the diagnosis, you're going to need to do an echo. So treatment. treatment for hypertrophic cardiomyopathy, the first thing that you always want to give these patients is going to be a beta blocker. Why do you want to give them a beta blocker? Well, as we went over before, you have this obstruction and you want more blood to come to the heart. You want that heart to fill up to decrease that obstruction. You want more blood to come into the heart so you can actually pump more out. So how do you do that? Well, you do that, let's actually throw the second one on there too. So you do that with either beta blockers or calcium channel blockers. Beta blockers are preferred just due to their side effect profile. And things like that. But the reason why you give beta blockers or non-dihydropyridine calcium channel blockers is because these both, they slow the heart rate. And if you have a heart that's beating 100 times a minute, how much blood do you think is going to get into the heart? Not a lot. It's pumping really fast. So if you slow down the heart rate, you have more time in diastole, more time for the blood from the atrium to get into the ventricles and pump out, more time to release that obstruction, to fill up the heart and lessen that obstruction. That's why you want to use these medications like beta blockers and calcium channel blockers. Now, beta blockers you use, and then calcium channel blockers, you're only going to use your non-dihydropyridine. So non-dihydropyridine medications are going to have an effect on the AV node and the SA node as well. They're going to slow AV node conduction, which slows the heart rate. The dihydropyridine, which are going to be your amlodipine and those meds, are not going to slow the heart rate. They don't have an effect on the AV node. So only calcium channel blockers, non-dihydropyridine. And the way that I remember the non-dihydropyridine, which is going to be diltiazem and verapamil, and I've never forgotten this one. This one's, and you'll always see it's going to be either diltiazem or verapamil. These are the most commonly used non-dihydropyridines. I highly doubt you'll see anything but these. The way I remember it is non-dihydropyridine, again, affect the AV node conduction. They slow the heart rate, so they decrease velocity of the heart by decreasing AV node conduction. Decrease velocity, DV, diltiazem, verapamil. There's your non-dihydropyridine, calcium channel blockers. There you go. You won't forget which ones those are. So if you have a bunch of, they say, which medication would you use? There's no beta blockers on there. They just list calcium channel blockers. They have amlodipine, verapamil, and then some other dihydropyridines. You think of decreased velocity and then look for diltiazem or verapamil. That's how you remember, because you'll see other calcium channel blockers in other questions as well, and you'll never forget that one. So now, if patients are refractory to pharmacologic therapy, there are a few more invasive options, and those are going to be either a septal myomectomy, which is quite simply you're going to cut out that portion of hypertrophied septum. That's all that is. You're just cutting it out, and you're going to lessen the obstruction by doing that. And the other option is something called an alcohol septal ablation, which is actually when they take it's about a 96% ethanol, and they do it through a catheter procedure. The catheter goes all the way down right into the septum, and then they release this alcohol into the septum. Now, the alcohol is actually toxic to the heart. It kills the cells of the myocardium. It causes them to shrink and die. And because of that, because of the death of these myocardial cells, it's actually going to cause the hypertrophy, the part of the heart, to actually shrink and decrease the obstruction. So a lot of times it can be refractory. It needs to be repeated, but it is less invasive, and it is another option for patients refractory to medication. So basically, you're spraying ethanol onto the septum of the heart, killing the heart cells, and decreasing this obstruction by decreasing or killing off the cells of the heart here. So that's pretty much all that is. So those are your options for treatment. Now, one last thing that I wanted to go over is in hypertrophic cardiomyopathy, exacerbation of the obstruction is seen in both increased contractility of the heart and dehydration. So because of that, what do you want to avoid in these patients? You want to avoid a few different medications. You do not want to give these patients digoxin. Why don't you want to give digoxin? Well, digoxin increases contractility of the heart. That's going to make the obstruction worse. Why do you want to avoid nitrates and diuretics? Both of those decrease preload, so it decreases the blood coming back to the heart, which again, remember, is going to close off that left ventricle. It's going to make the obstruction worse. So that's why you don't want to use nitrates and diuretics. In the same way that dehydration is also going to decrease preload and also going to make the obstruction worse. And that's the same reason you avoid dehydration and exertion. Exertion is going to cause increased contractility of the heart. Dehydration, decrease your preload, same way the nitrates and the diuretics work. So anything that's going to decrease the amount of blood coming back to the heart or increase the contractility is bad. So no digoxin, no nitrates, no diuretics, and these patients really should not be exerting themselves, and they should not become dehydrated. Those are the things you really want to avoid in children with, or adults with, hypertrophic cardiomyopathy. So those are the main things that you need to know, that you need to avoid in these patients. Now, what do you need to know? You need to know this is an autosomal dominant genetic disorder that leads to mutations in the sarcomere genes. You need to know it's a harsh systolic murmur that's best heard at the left sternal border. And remember, increases with decreased venous return, less blood coming back to the heart makes the murmur worse, and decreases with increased venous return. So it gets better when you have more blood coming back to the heart. And then finally, remember your first line pharmacologic agent is going to be your beta blockers. So that's what you really need to know with hypertrophic cardiomyopathy. And let's take it home with test your knowledge. We'll do 5 quick questions to see what you remember from what we just learned. So what is the most common type of cardiomyopathy? That is going to be dilated cardiomyopathy, over 90% of the cases. What are the 4 known classes or medications known to reduce mortality risk in patients with heart failure? Really hope you remember this one because I worked hard on that mnemonic, and that is going to be your BASH meds. So beta blockers, ACE inhibitors, spironolactone, and hydralazine with a nitrate. Third question, what is the most common cause of restrictive cardiomyopathy? Again, you'll hurt my feelings if you don't know this one because I think that mnemonic was pretty good. So that's going to be amyloidosis. Remember, Amy has restrictive cardiomyopathy. So amyloidosis, most common cause of restrictive cardiomyopathy. What is Kussmaul's sign? So remember Kussmaul's sign from the right side at heart failure. It's going to be an increase in jugular venous pressure with inspiration. So opposite of what a normal patient would have. And then finally, what is first-line pharmacologic agent for treatment of hypertrophic cardiomyopathy? We just went over that one, and that's going to be beta blockers. So those are your questions. Hopefully you got those all right, and I hope that helped. That was a little bit longer than I would have liked it to be, but I think it's pretty important information, and I really wanted to make sure you understood and everything. So thank you so much for listening. Thank you for all the likes, the new subscriptions to the channel. I really do appreciate everything, the comments, and good luck on your PANCE, your PANRE, your EORs, and good luck in PA school.